makes a person to have a unique experience and also happens to be a little different from each other. Experiences build the brain architecture, and infants and children experiences provide the framework for other forms of development. Even adults experiences alter functioning and learning, as we shall see later. So there is what we call brain plasticity, which simply refers to the ability of the brain to reorganize neural pathways throughout the lifespan as a result of experiences. Every experience is important. It can change the way you look at things and provide some learning. Put simply, it's the ability to change with learning. There's a change in the internal structure of the neurons, notably the synapses, and this increases as the person grows in the early years, as we shall see later. So the neuron is the raw material for the brain. It's the foundation actually, and we have about 100 billion neurons at birth. Most of what we need throughout life has to be determined by these neurons, and these neurons are a way to connect, to be able to link up with other neurons. But as you can see, a baby's neuron has no myelin sheath because it is not fully developed. So these can be in many numbers, but no connections. So the connections start to form shortly after the baby is born, and this happens for a long period of time until the baby reaches the peak, as we shall see later. So put simply, the neuron is the nerve cell, and we are going to be referring to it. That's its structure, and I think you can see the connections, the synapses between each of these neurons. They join together and help us perform important functions. At birth, we has many neurons, but with few connections. So these neurons are the building blocks. But at birth, they don't have the connections. They later. Connections are strongest in the brain stem, which is responsible for things like breathing, digesting, eliminating. This ensures that at birth, your baby has the reflexes to keep the airway clear and seek food. So babies have connections in the brain stem because they need to breathe, they need to eat food and cry. But these connections are weak in other parts of the brain that are responsible for balance, spatial understanding, hearing, language when somebody's a baby. These form later. The connections between the neurons form later, and they later super dense as the person develops. Baby's brain is especially mature in areas related to control of emotions, the limbic system, concrete thinking, decision making, and so on. The connections build, and when cells each other, the axons send messages or electrical impulses, and the dendrites receive them, and vice versa. So the cells start to build connections, the synapses, and over time there gets to be more and more complex connections, which look like roots on a branch. Each neuron may have thousands of synapses. These connections help the brain process information more efficiently and take more action. That's an illustration of the connections that are. So put simply, synapses organize the brain by forming neural pathways that connect parts of the brain to enable us breathe, sleep, think. I think you can see. But in between here, there are neurotransmitters that move between the space. Synaptic formation when somebody is born happens to be not dense initially. As the person begins to grow and comes to 2 years, they start to become dense. So the synaptic formation increase in number. By age 3, they're about 1,000 trillion. And By age 7, it's dense. I think you can see its peak is between 4 to 8 years. So after 8 years, they start to become fewer, as you can see in this diagram. Put simply, these connections help us to acquire more functions and perform well, but all the cells, all the synapses that are not put to use start to be pruned after 8 years. So I think you can see they are becoming less and less. So by age 10, they are becoming fewer, but you see at age 7, they are dense, super dense, 7, 8 dense. So as the at birth, there are few connections between the neurons. By the time the child is 3 years old, the brain has formed about 1,000 trillion connections, about twice as many as adults. A baby's brain is super dense and will stay that way throughout the first decade of life. At the peak of building huge numbers of connections, that's around 48 years, children may have twice as many synapses as adults. After age 8, a child's brain gets rid of the extra connections in a process called pruning. There is a phrase we use it or lose it. Every connection that's not put to use lost. So children do a lot of pruning around age 10. So if there's anything that you want your child to learn or make them remember, you measure at this age when those cells, when the connections are not yet pruned, they are still there. Because after age 10, whatever is not put to use is going to be pruned, and they start to become fewer, but those are left to become more stronger and provide a wiring that's more powerful and efficient for the entire life after that. So I think you can see this is important in parenting and child development. The age 10 is very significant. It's a transition that whatever is not put to use has to be pruned and lost totally. As you can see, most of the synapses formation happens to be before birth. As you can see, communication starts before birth, 3 months before birth. It starts, and this synaptic formation happen to go to the peak around 7, 8 months. It's important here to talk to the baby while in the womb, because their sensory hearing abilities happen to start to be stimulated. Here, if you can see, the orange is for the sensory, that's hearing and visual. So I think you can see by 0, that's when it shoots. So there are what we call critical periods and sensitive periods. If at this time a baby's sight is not stimulated, for example, and then the baby's eyes are opened around age 6 months, it may be difficult to develop that sense, because the connections have not been put to good use, and some of them have been lost. So it's important that we measure on what stage that we can focus on to help a child acquire more. As you can see, language, it's important to talk to the child while in the womb, because they perceive language before birth. That's 3 months before birth, they can be able to perceive something you tell them. So it starts that stimulation early, much earlier in life. As you can see, for higher cognitive functions, it goes to the peak around 12 years, and then it starts to decline. So at a point when it declines, that means the connections that were not put to use are pruned away, and it starts to go down, as you can see. So this is important in child development and rearing, to know when to support a child to acquire what ability, and be able to train them effectively, as we shall see. We have neurotransmitters, chemicals that affect the formation, maintenance, and activity of neurons and synapses. They excite or inhibit function. So we have over 50 neurotransmitters, but we shall just talk about a few, like serotonin, which impacts on every part of the body from emotions to motor skills. Serotonin is considered as a natural mood stabilizer. It's the chemical that helps with sleep, eating, and digesting. Serotonin also helps to reduce depression and regulates anxiety, promotes wound healing, and maintains bone health. So it's quite important. Low levels can lead to depression and other problems, but high levels muscle rigidity. So we just need the right level. We have the endorphins, which help reduce pain and promote euphoria and determination. We have cortisol, which activates the body defenses when the body is under stress. When the brain goes into survival mode, the flight or fight, the cortisol is released when one is under stress. We have melatonin, which helps with sleep and rhythm. So we have adrenaline, which heightens awareness, and we have dopamine, which helps us in the reward and motivation and allows us to feel pleasure or satisfaction. There are many of these, but we are going to look at how these might be helpful and how we can make use of this learning. Oxytocin, some books call it the love hormone, promotes trust and belongingness. I'll give an example. When you coo and baby, it communicates that it's a safe environment, and they happen to develop trust, love, and belongingness. So most of the mental problems we see among adults start much earlier when people are younger, depending on the environment where they've grown up. The connections that a parent or caregiver assist with the child's environment are what spur the growth patterns of these connections, the interactions, talking to the baby, cooing, smiling. So these connections build through experience of interacting with a giver. So this is very important for mental health in the development and prevention of mental health problems among children and later on as adults. Stimulation of these connections happens, and there is what we call early sensory stimulation. So in order for our senses to work, they need to be stimulated. So multisensory activation can focus on touch, taste, visual, hearing, smelling, and this is the result of the stimulation of the neural connections. So if they are not activated at the right time, they may not be activated. But we hope for another period of what we call brain plasticity, that some learning can still take place. A young baby makes connections all the time, up to 700 connections per second, neural connections. Can you imagine? Up to 700. But remember, we started by saying they are born without these connections. They are born with so many neurons, but they start to form these connections as the senses develop. And connections help in the formation of habits, conscience, memory, mind, and serotonin plays a role, and cortisol plays a role in how the brain develops and builds electrical transmission across the neurons and connections. So the 5-HT or serotonin is produced naturally when a child feels loved, cared for, and happy. So it's important to smile to the babies and make them feel comfortable. Myelination happens as the brain cells mature. They become surrounded by myelin sheaths, a dense fatty substance that insulates the nerve fibers and helps with a clear, efficient transmission of messages. I think you can see at birth, the baby's neuron doesn't have a myelin sheath, but later on it starts to form because this myelin sheath helps in the processing of information. Infants and toddlers have have not developed much myelin fish. That's why they seem process information much slower. So when you're dealing with them, you need to repeat many times and emphasize some points. This process of myelination continues through your child's teen years and in the early 20s. So it keeps on until the 20s, I think you can see. There are critical and sensitive periods. Critical period is a limited time that begins and ends abruptly, during which a specific function develops. Conditions for development are not available during that time. It may be extremely difficult or even impossible for these functions later in life to develop. When the body is not exposed to the right stimulus, it simply doesn't develop that ability. And once it's missed out, it's gone forever. That's what we call a critical period. An example is the visual stimulation. If the visual stimulation doesn't occur at the time and somebody's eyes are closed, maybe you close the eyes for 1 year and then open them after, it may be very hard for that person to have vision. So the stimulation has to be done at the right time so that we don't lose out. Now, important in parenting, of the children that we come across, or even some of us have not had this knowledge. Our parents never had this knowledge. They may have missed out in critical periods that they would have taught us specifics, and we might happen to struggle throughout life to learn a specific that could have been attained at an earlier stage of life. Now, we also have the sensitive period or the window of opportunity. It's a time when it's easiest for the child to acquire a certain skill or learn something. It's similar to the critical period in that it is a time of optimal development, but it's best understood as a time of maximum sensitivity that begins and ends more gradually and is more amenable to recovery. So there is a period when you have to take advantage of enabling a child to learn a specific skill. That's a window of opportunity when it is really extremely sensitive that you make use of that time, as we can see. If a child needs are not met, they can get stuck in the survival mode and have a hard time developing higher functions. When a child is frightened, he may go into the survival mode, the fear of flight, and this releases the cortisol and the typical of children who go into tantrums as a form of regression because they have not acquired the higher functions to be able to deal with their frustration. So even some adults regress and go into tantrums when they are challenged. So I think you can see why they do that. It's because they are threatened and the brain has to go into a survival mode. So some people get stuck into the survival mode and happen not to resolve issues well, even later on as adults. Next to develop is the sensory cortex, which is next to the occipital those visions, and then the parietal lobe for touch, and then the frontal lobe, which addresses hearing and language. But other centers develop diverse experiences, including outdoor play, cuddling, reading to your child, playing. These can help this sensitive period for the child to acquire specifics. So it's important, despite our busy schedules, to have time for our children and read to them, sing to them, because we are developing specific and helping them to be better than us. The cortex later develops, which has to manage concrete thinking, and these skills happen to build from preschool to early adolescence. So optimal development of the cortex requires health development of the midbrain and the brain stem. The prefrontal cortex also develops later, which helps to handle the executive functioning of the brain, like planning, reflecting, reasoning, abstract thinking. It really develops through the age 22 to 25. That's why don't wonder when a student in this age category makes a terrible decision. Perhaps the prefrontal cortex is still developing. Yeah. So as you can see, we can help and support our children to develop specifics and develop their brains by knowing what to do. I think you can see as we go around the parietal lobe responsible for language, talking, singing to the child and listening to them, reading to them is very important. Develop that faculty, which happens from birth to 6 years. Here you have to note that the time frame is the sensitive period when it's easiest to develop a specific ability. When that part of the brain is growing and developing, and the brain grows and changes throughout the child's life. You can see the parietal responsible for touch. You have to touch the baby, hug the baby, you know, massage, give lots of objects to manipulate and help them to explore, pull, push, pick, and so on. So, you know, when you do those things, you're developing a specific part. Then we have the occipital lobe, and this one helps, is stimulated between birth to 2 years. And you have to stimulate the sound and look at the games that can help a child follow, make sure that children have plenty of outdoor activities and the develop area by area. I think you can see around. Some areas are responsible for language, visual processing, balancing and coordination, and so on. Breathing, heart rate, and so on. So at each of these areas has to be supported to develop. When a baby is frightened, you have to, you know, give them some soothing to enable them shift from the survival mode to a happy and trusting mode that can help people form trusting relationships. This area, the frontal lobe, which develops much later, can help a person develop thought, memory, and behavior. So here you have to encourage problem solving and support the child when frustrated, help them notice patterns and develop solutions to problems. But we have the prefrontal cortex, which develops 12 to 22 years. I think you can see. You give children choices, all these young people choices, and talk to them, help them break down big tasks in small tasks. As you can see, then we have the hearing, learning, and emotions. And here you stimulate each area to make sure that the child learns and grows well as a result of the right stimulation that's taking place and the right development of the brain and you know, faculties. So we have to make use of the sensitive periods. I've been showing the years here, as you can see them. Those are years during which you are able to achieve that specific skill or sets of skills. But when it passes, it may extremely be very difficult. Now, importance in child and adolescent mental health. Development brings unexpected periods in which emotions or impairing behaviors may occur as part of the normal transition, like in or when children have a separation anxiety, when starting school, or positionality in a 2-year-old and adolescents. So you have to look at what went wrong. Psychiatric disturbances in children often consist of lack of developmental progress in one area or more domain rather than the presence of specific problems that are characteristics of adult disorders. So a child's developmental status may affect the clinical presentation of various syndromes like depression, often present within irritability and somatic problems. So you can look at a proper child assessment, look at how you can support the person. There are factors that influence development, which include genetic or environmental. These are crucial. We have the long-standing nature-nurture debate. environmental factors affect brain development. We have those that are antenatal, like early maternal infections, rubella, toxoplasmosis, late maternal infections, including HIV and malaria, toxins, smoking, alcohol, pesticides, drugs, but we also have postnatal infections like meningitis, metabolic syndromes, toxins, lidomacular trauma, severe under-stimulation or maltreatment, malnutrition, vitamin deficiency, maternal mental health disorders. If a parent has depression, certainly the child has to be affected. So here we have critical periods or red flags that happen to rise when a faculty is not developed at the right timing, as you can see. Child development occurs depending on the age. So at 6 weeks, you can see gross motor skills that develop and the fine motor. But we start looking at the red flags when some things are not happening right. Like if at 6 months, there is no head control and baby is floppy. At 9 months, if the baby can't sit unsupported, or if at 12 months, the baby is not able to weight bear, or if at 18 months, the baby is not walking, or he cannot run at 2, those happen to be the red flags, as we shall see. So we need to identify these early and be able to give the appropriate support. So red flags can be at different levels. If a child at 6 weeks is unresponsive to sound or stimulation, that's a red flag, or lack of social responsiveness at 3 months, or 6 to 8 months, poor head control, 9 to 11 months, can't sit unsupported, or 12 to 18 months, not walking, absence of language, or 18 months to 1 year, lack of social interaction, then the red flags is. But there are those between 2 to 4 years. If a child is not able to climb upstairs, not able to build a tower, not able to identify objects in picture, not curious, then that's a red flag. Child not able to climb upstairs, delayed self-care skills, not able to copy the circle, no theory of mind, limited social interaction, lack of symbolic play, 3 to 5 years, preschool, then you know there is a problem. Then there are those red flags, 6 to 9 years, poor motor coordination, gross developmental difficulties, unable to separate from carer, frequent or prolonged temper tantrums, poor emotional regulation, inattention, and lack of interest in learning, undeveloped social skills. 6 to 9 years, then that's a red flag. But we have 10 to 18 years, poor peer integration, poor sense of self and self-regulation, 10 to 13 years, and poor body image, distortion, lack of independence, inability to regulate, poor self-care skills, poor abstract thinking, 14 to 18 years, then that's a red flag. The alerting red signs and red flags, and we divide this into 4: developmental delay, developmental disorder, developmental variation, and developmental regression. Let's look at one by one. In developmental delay, we look at significant delay in 2 homodomains, performance of 2 standard deviations below the mean on age-appropriate standard norm referencing tests. This can result from innate environmental factors. Press the one unmuting to mute kindly. It's for children below 5 years in the UK and the US, this developmental delay. But have 1 to 3% of children who present with that. That's statistics from the West. I later come to our statistics here and work that we have done. We have the second group, that's developmental disorders. Heterogeneous group of conditions that start early in life and present with delay or abnormal pattern of regression in 1 or more domains. Have autistic spectrum disorders. We have attention deficit type disorder, hyperactivity disorder. We have autism spectrum disorder. We have developmental coordination disorder, we have specific learning disorders, we have global developmental delay. In this developmental coordination disorder, the child is clumsy and has minimal brain function. It's multifactorial in origin. They are difficult with motor function and not primarily due to general intellectual impairment. So there are subtypes of developmental coordination disorder, deficit in conceptualization, planning, and executive functioning or motor organization. It interferes with the child's academic achievements and activities of daily living. It overlaps with the ADHD, tics, or Tourette syndrome, ASD, specific learning disorders, and language disorders. There is a lot of comorbidity among these disorders. There's developmental variation. Normal patterns, late walking or talking, or it can be early. Receptive language precedes language expression. Black and Indian infants are more likely to have advanced motor skills as compared to European infants. There are those correctable causes for slow development and nutrition, failure, iron deficiency, anemia, isolation of the family, or maternal depression and hypothyroidism. We have developmental regression, the fourth subtype, which is loss of previously acquired skills, can affect end domain of development. It's caused by innate or environmental factors. Under the DSM-5 classification, childhood disorders are classified into neurodevelopmental disorders and disruptive impulse control and conduct disorders. This DSM-5 diagnostic and statistical manual 5, which we use as our Bible, has changed several things, like mental retardation is now called an intellectual disability. There are several other changes that happen. But the DSM-5 childhood disorders include child intellectual disability, specific learning disorders, autism spectrum disorders, motor disorders, communication disorders, attention deficit hyperactivity disorder, feeding and eating disorders, which includes anorexia nervosa, bulimia nervosa, binge eating. We have disruptive mood dysregulation disorder. This was put in place to reduce on the frequent diagnosis of bipolars among children, because sometimes these children or young people have a condition which is extreme irritability, anger, or frequent intense temper outbursts. You have seen these big boys in our houses. Sometimes they shout. So you can't say they have bipolar, but that can be classified under disruptive mood dysregulation disorder. It's common among youth, young people. We have the trauma and stress-related disorders. We have the disruptive impulse control and conduct disorders. We have the anxiety disorders. Look at these neurodevelopmental disorders, intellectual disabilities. We have intellectual disabilities like intellectual developmental disorder, global developmental delay, unspecified intellectual disability. And we have communication disorders, among which includes language disorders, speech sound disorders, child onset fluency disorder, stuttering, it's common, a social communication disorder, unspecified communication disorder. We have autism spectrum disorder. We have attention deficit hyperactivity disorder with 3 types. There is combined, inattentive, and hyperactive impulsive type. We have specific learning disorders. We have motor disorders, which include developmental coordination disorder, stereotypic movement disorder. Here you have to specify whether it's not associated with a known medical genetic condition for it to be a stereotypic movement disorder. We have the tics, Tourette's disorder. We have persistent motor or vocal tics. We have provisional tic disorders. We have other specified tic disorders, unspecified tic disorders. These tic disorders, if I found them common among children with HIV in our previous studies. And we have neurodevelopmental disorders, other neurodevelopmental disorders, specified neurodevelopmental disorders, and unspecified. Now, among the impulse control and conduct disorders, we have the opposition defiant disorder. These are children who go against what adults tell them to do. They are oppositional, they are defiant. Then we have the intermittent explosive disorder, repeated sudden episodes of impulsive aggressive violent behavior, angry verbal outbursts in which the person grossly reacts out of proportion to the situation. Some of these children break tables or hit the tables. So we have those, but we have the conduct disorder as well. These are children with a pattern of disruptive and violent behavior, and have problems following rules. They have problems with police, and they are associated with the criminality, stealing, setting houses on fire, sleeping out, going and sleeping out, and fighting and delinquency. We have kleptomania, we have other specified disruptive impulse control and conduct disorders. We have those which are unspecified. Now, some disorders among adults also occur among children, and these include schizophrenia spectrum and other psychotic disorders, bipolar disorders, depressive disorders, anxiety disorders, obsessive compulsive and related disorders, trauma and stress related disorders, dissociative disorders, somatic symptom. This one is common in liaison practice, in liaison mental health or psychiatry. Children who present with physical complaints, but when there are problems are psychological. And sometimes they move from one expert to another, trying to take investigations, and they believe they have a problem. But when you examine them or do the CT scans and all other investigations, they are normal. Their systems are normal. Sleep-wake disorders, sexual dysfunction, gender dysphoria, a sense of unease that a person may have because of a mismatch between their biological sex and gender identity, disruptive impulse control and conduct disorder, substance-related and addictive disorders, neurocognitive disorders, paraphilic disorders, recurrent intense sexual arousal with objects and other things. So all these can occur both among children and adolescents, but there are other common disorders among children and adolescents, which include depressive disorders, disruptive mood dysregulation disorders, anxiety disorders, and obsessive compulsive disorders. These are characterized by ritualistic habits like washing and a strong thought of obsession. They have an obsession and a compulsion. The obsession is the thought, and the compulsion is the act. They can have ritualistic habits like washing, cleaning, and not ending, and on. We have the trauma and stress-related disorders. These are very common. I'll show you a study done by one of our colleagues, Dr. Bo, where PTSD and related disorders were high among children in the refugee and war-troubled areas in the north area, children who had to survive trauma and went through quite a lot. But we have other disorders like dissociative disorders and somatic symptom. We've talked about that. And feeding and eating disorders, rumination disorders, anorexia nervosa, binge eating, or bulimia nervosa. These eating disorders are common among children in the West, not very common among children here, but they are there. Either a child eats and vomits, he purges to vomit, or he never eats. He refuses to eat. Elimination disorders, these are common here. Enuresis, children who urinate and defecate on bed, these are common here. we see them in our clinics. And we have another time bomb here, the substance-related and addictive disorders, alcohol-related disorders, caffeine-related disorders, cannabis-related disorders, inhalant-related disorders, opioid-related disorders, sedative, hypnotic, and anxiolytic-related disorders, stimulant-related disorders, tobacco-related disorders, other substance intoxication, non-substance related disorders, e.g. gambling, betting falls here. Yes, these are on the rise, and studies done in schools at the neighborhood reveal that these students and pupils use these substances. But on a sad note, we have not done screening here. We haven't done screening here, so it makes it difficult for us to know if they are really there. But in our schools, these problems are there, substance-related disorders. But and done the screening in schools, and we need to do the screening because we have schools, and the policy, the child adolescent mental health policy, which is about a screening of all school-going children, but haven't done that. We lack the capacity. So those are things we need to think about. Other conditions that may be a focus of clinical include relationship disorders. These are many. We have abuse and neglect, child maltreatment, related problems, child abuse, child sexual abuse, physical abuse, sexual abuse, child neglect, child psychological abuse, housing and eco problems, inadequate housing, lack of food, water, extreme poverty. Some children are living in abject poverty, and that impacts on their mental health. Broadly, sometimes we use two broad categories of externalizing disorders, characterized by outward direct behaviors, non-compliance, aggressive overactivity, impulsiveness, which includes ADHD, conduct disorders, opposition defiant disorders. These are more common in boys, or we can use another term, internalizing disorders, characterized by inward focused behaviors, depression, anxiety, social withdrawal, and mood disorders. These are more common in girls. Now, the epidemiological framework that we use is this one, that is multifactorial for the development of these problems. We have predisposing factors, which include genetic endowment, temperament, gender, low IQ, perinatal adversity, physical attributes. Then we have the perpetuating factors, early infantile experiences. We have the social-cultural factors, family factors, and we have the precipitating, like life events, current family psychopathology. All these lead to a problem. So for us to be able to address these problems, we need to look at how do we start to approach. As you can see, we have predisposing, perpetuating, precipitating factors that lead to causation. So the risk factors that we commonly see in our clinics include chaotic families, parental substance misuse, domestic violence, mental illness, learning disability, parental history of poor parenting. In our clinics, some parents use aversive measures. I received one parent tie his child upside down for weeks, but he would go and feed that child in an upside down position. And when I interacted with this parent, the father, he told me, no, that is even light. My father used to do worse things. So there is that parental history of poor parenting that one happens to pass on to the child. Lack of family support or isolation. We have multiple transitions. They are very, very significant as being risk factors to child poor outcomes and mental health problems. Parental chronic self-harm, parental culture or religion, uh, involvement in antisocial criminal behavior, negative peer influence, exposure to substance use, domestic violence, not attending school is a risk factor. We have those risk factors specific to maternal, like education level attained, maternal age, marital status, prenatal care, smoking during pregnancy, alcohol intake, medical, maternal medical history, complications during labor or delivery. But we have those child-related risk factors like below gestation age below 37 weeks, birth weight less than 0.5, small babies, upper cost less than 7, multiple births, presence of newborn condition, presence of congenital abnormality. But there are other risk factors which are significant. Genetics, deaths of significant person, discrimination, low IQ, family breakdown, disaster, physical illness, marital conflict, homelessness, economic factors, difficult temperament, rejection, significant life events, communication problems, abuse, which can be in many forms, parents with mental health problems, academic failures. But we have also the protective factors like priority being given children, having a secure base, parental positive attitude to pregnancy and birth. Some children get rejection right from the time they are in before birth because the mother didn't want the pregnancy, and that attitude can affect the inborn. Parental insight into own behavior is also another strength. If a parent's attitude and experience is good, certainly we expect good outcomes. The parent knows I'm supposed to do this. Availability of family support that encourage communication, application of motivational strategies, health checkups, being able to attend a family physician, pediatrician, child adolescent mental services, all those are protective factors. And luckily enough, we have a service in this country, school mental services. These can help detect the screen and detect those who have problems, early identification and intervention. But on a sad note, I think we are not having active school mental health services. We have it on paper, but it's not been implemented. Police can be put to good use because they have the child protection and family services. So this can attend to their children's mental health and help mitigate some of these problems. So in this country, we have the child and adolescent mental services, but located at specific facilities, as we shall see later. When looking at psychopathology, what constitutes these disorders in children? For a child to have a psychiatric disorder, the following must be met. The behavior or emotion must lie outside the normal range for their age, and ordinary developmental functions impaired in association with this, or substantial suffering experienced as a consequence, either by the child or others. So here we have a timeline. So I think you can see these disorders have a psychopathology that happens to relate to specific years when we expect specific problems. So the timeline for psychopathology in children and adolescents here, as you can see, around birth to 18 years, we expect disorders of sleep, feeding, attachment, non-organic failure to thrive. And then language disorders, developmental disorders are common between 18 months to 3 years. Autism spectrum disorders and elimination disorders, defecating on bed, urinating on bed are common between 3 to 5 years. This is preschool. Then the attention deficit hyperactive disorder, opposition defiant disorder, tics, authority disorder, anxiety disorders, conduct disorders, childhood depression are common between 5 to 12 years. That's the school primary school years. Then in the adolescence, what we expect is the obsessive compulsive disorders, eating disorders, anorexia nervosa, bulimia nervosa, substance use, affective disorders. That's between 12 to 16 years. But after 16 years, we'd expect bulimia nervosa, psychosis, schizophrenia, and other schizoaffective disorders may sit there. So this helps us to know what we might expect at what specific age. So it's a timeline for the psychopathology, and it's quite helpful in our work. As you look at this developmental approach, these factors are in a cycle. So we have the age-specific risk factors, preconception, we have the prenatal, we have the infancy or childhood, we have the school age, we have the adolescence, and it's a cycle. So this approach helps us to look at specific factors that we can address in order to help children overcome their mental health problems. So the burden here, now I'm right at the burden. Globally, these child and adolescent mental health problems in 17 years, all children and adolescents are 20%. So these are Ministry of Health document, and then this publication, Thoman, 2016. But we also have prevalence among adolescents in northern Uganda. Post-traumatic stress disorder, like I said, it's common still among children and among adolescents and even adults. So a study by Dr. Kathy Abo revealed that PTSD in the population of adolescents in northern Uganda was 26.8. This is very high. Major depression was 19.5, generalized anxiety disorder 13.4. This is a published study. You can look at this. So we're looking at the burden. Do these problems exist? The answer is yes. On a sad note, a lot is known about the burden of neurocognitive and psychiatric problems among children with HIV, or those exposed to conflict like in the northern Uganda, but not in the general population of children attending normal schools. In a study that we did with my team, we realized that psychiatric disorders were very common among children and adolescents with HIV with high rates. You see, 32% emotional and behavioral problems, and you can see ADHD was prevalent. Here, emotional problems were 27%, and we had all the disorders present, I think you can see. And some of them met the psychiatric criteria. Diagnosis like psychiatric problems were 6.9%, but among the population of children, adolescents with HIV. On a good or sad note, most of the studies are being done in the clinical population, children, adolescents with HIV, and children in conflict areas, adolescents in conflict areas, but not in the general population. So we don't know much about what's in the general population. But recently, we did a study with my group and looked at schools around Entebbe, and we realized that there is a shared risk factor for mental disorders regardless of whether somebody is vulnerable or not. So let's not focus on the clinical population, children with HIV and those in conflict areas, but we should focus on even the other children who are attending normal schools. Many children in schools may be battling with mental health problems that are not recognized. Children and adolescents with health problems have been supported this policy, though we haven't implemented it to a greater extent, but as part of this policy, the child and mental health policy that recommends screening for mental, neurological, and substance use disorders among school-going children, but this has not happened. So as we near our discussion, let's start thinking, how do we start? Do we have these problems in schools or don't have? How can we start to address this problem? So in a study that we did around the peri-urban schools in Entebbe, this is a published study, we realized that children suffer from these disorders, but they are not identified. So the prevalence of neurocognitive impairment and psychiatric disorders, a sample of non-clinical school children and adolescents living in peri-urban Entebbe was major depressive disorder was 5.9, ADHD 2.8, generalized anxiety disorder was 2.2, and disorder was 8.6. You see, in the general population, there is some substance use disorder, and prevalence of any psychiatric disorder was 9.3. So these problems are common even among children, adolescents attending normal schools. So I think we need to focus broadly on most of these schools. This was a smaller study around the Entebbe only in the peri-urban setting, but we haven't done similar studies in the West, the East, or the Central here. So we need to do more to identify most of these problems so that we don't only focus on the clinical population and children, adolescents in conflict areas, but focus on all the other areas. It's important for professionals and parents to have a responsibility to monitor and support child development so that optimal developmental progression is assured and risks and difficulties are detected and addressed. So children and their caregivers should make health visits to child, adolescent mental services. We have one in this country. There's need to reassure children, adolescents, and parents about, the possibility of treating these problems. It's important to focus on the parental competences and look at how best we can parent and offer strategies to mitigate difficulties resulting from negative parenting. It's important to provide anticipatory guidance to those that need it. There should be early detection of developmental risks and difficulties, and we need to activate school mental health. It's important to empower caregivers to support their children. This is a parenting pyramid that can be able to help some of us. It helps to focus on build the foundation for learning parenting approaches that create a strong bond between you and your child. A positive relationship that you give to a child and help the child to outgrow the difficulties. So as you can see, the different problems require different strategies. So you need to look at what problem is this child having and how can I address this. Parenting is very important and can result into better outcomes. So it needs to be consistently provided, and children can be helped to acquire specifics. So there is need for protection, care, availability, sensitivity, acceptance, validation, social interaction, stimulation, and the right level of discipline when parenting. But on a sad note, most of this has not happened. Negative parenting can be harmful, and it can destroy the child's sense of esteem and other faculties. So some disciplines used are harsh, some are corporal punishments. There's lack of protection for the child rights here. Sometimes it's left on paper. There is a lot of neglect, unavailability, insensitivity, negative attribution, lack of validation, and coercive parenting. Yeah, some parents proudly come to clinics and tell you they have had to beat their child 100 canes. And they tell you this was little, their father used to do 200. So I think we need to alter and change the parenting approaches and practices. Now, we have services in this country. We have our consultative services, health promotion, we have training, the child and mental training at Butabika between Mbarara University and Butabika. The enrollment is at Mbarara University, but the training is at Butabika Hospital. So we have specialized child and adolescent mental services. So here, we provide assessment, family-based interventions, family therapy, parenting support, directly work with children and young people, and also do counseling, cognitive behavior therapy, solution-focused therapy, eye movement sensitization, reproduction therapy, psychotherapy. Those are several. So moving forward, we need to deal with the burden of mental health problems in the non-clinical, non-vulnerable population of children and adolescents attending schools in Uganda, and offer services to those identified with need for early intervention. We need to adapt and develop locally appropriate instruments for screening, monitoring emotion and behavior problems among youth. We need to develop a Ugandan specific tool that can help screen. I developed this one and published a paper out of it. I developed a tool that screens for the 8 most common disorders and published a paper out of this. Those are the details. So we need to develop more tools to help us in the screening and diagnosis that are tailored to the context here. We need to pilot the interventions, selection be guided by formative work to assess the feasibility, accessibility, and trends. What interventions can help our people here? How do we start to overcome this challenge? We need to operationalize the Uganda government policy to establish youth-friendly corners at all public health centers. Right, Rural Center 3. I challenge the DHOs on this platform. In your district, do you have any facility that youth-friendly corners? Because those points where we can offer mental health and support people that need the services most. So many publications about child and adolescent, but I picked out a few that are important, like the ones for the validation of the tools. That may help us get started. Adaptation of the DSM-5 based psychiatric scale for child adolescent mental health in Uganda. This is a good tool. That one we developed with our team and published a paper out of it. And have another good tool here that we some time back, the CASI 5. So that ends my presentation, and the question to you is, how can we promote child and adolescent mental services in Busoga, Eastern Uganda? Contributions are welcome. Thank you for listening to my presentation.
As Busoga Health Forum and for the members that have attended, accept this certificate that is offered to you for the good work that you've done. Thank you so much, Dr. Mpango.
Thank you very much. I'm exceedingly humbled and honored.
And in the same vein, I would like to take this opportunity to thank Professor Emmanuel Otieno for having taken us through this session. It has been a long one, but you've really been patient with all of us, the listeners and the presenter and everybody else. Thank you for your time. We know you're busy, but it's always good when we have someone who can give us all this time to participate in this forum. Thank you so much, and please accept this certificate as our appreciation of your efforts and your contribution. Thank you so much, Professor Otieno.
Thank you very much, so much, Dr. Kagwa. Yeah, thank you.
So over to you, Professor Waiswa. Thank you for the opportunity for me to participate in this handover ceremony. Thank you so much.